Economics of Cancer Research Group webinar. So today we're very proud to have Dr. Otis Brawley, who's the Chief Medical Officer at the American Cancer Society. So he's going to speak on a range of topics related to the economics of cancer in the US. So without further ado, I'm going to let Dr. Brawley take it away.
Good day to you people around the world. It's a pleasure to be here. I'm going to talk about cancer control, health disparities, and have a particular look at what's going on in the United States economy. In terms of disclosures, these are the things that people should know about in terms of where I make my money and what I do. I've also published a book called How We Do Harm, which I also think is pertinent as in terms of disclosure. An overview of my talk today, I'm going to talk about the health economy, cancer outcomes, in terms of disparities, what is working in terms of decreasing mortality and decreasing disparities, a little bit about the causes of cancer and where we go from here. First, in discussing the economics of health care in the United States, which is something that is in the news quite a bit here in the U.S. these days. We spent $2.6 trillion on health care in the year 2010, which is quite a sum. We spent $2.6 trillion on health care at a time when we spent $1.1 trillion on food, and personal consumption in China was $1.4 trillion. Health care in the United States is 17.9% of our gross domestic product. To put that into perspective, we spent $2.6 trillion on healthcare in the United States, and the entire economy of France, the fifth largest economy in the world, was $2.56 trillion. So we spend an amazing amount of money on healthcare in the United States. At the same time, our outcomes are not very good. I've compared Canada and Switzerland, which are two of the more expensive OECD countries in terms of health care, to the United States. I just note that in terms of infant mortality, we don't do very well. In terms of white male life expectancy, we don't do very well. You can see the per capita cost for health care there, with the United States at $8,200, Switzerland at about $5,300. And in terms of proportion of gross domestic product, we're at close to 18%, where the Canada and Switzerland are at about 11.4%. The United States has a huge problem in healthcare, in that not only is it inefficient, we have terrible outcomes compared to other countries. We are a country where a number of people overconsume healthcare and get too much healthcare and are actually harmed because of it. A number of people underconsume and they get harmed because they don't get enough health care. And our healthcare outcomes could actually be much better if we got more efficient in terms of our healthcare system. In terms of the growth of our percentage of gross domestic product, there are projections that healthcare in the United States might be 30% of our gross domestic product by 2030, and indeed this is a fiscal cliff that we just cannot tolerate. The increasing costs of health care are simply not going to be tolerable to the economy. It will cause the economy to crash. At the same time, we have tremendous threats to our health consumption. This is just the proportion of adults and children who were obese in 1970 compared to the proportion who were obese in 2008. The obesity epidemic in the United States is an amazing phenomenon. You can see the increase in obesity in the United States versus a number of European countries as well as Korea. And we have a huge problem with obesity in the United States, which is only going to cause increased consumption of health care, perhaps above that those estimates that I've given you, the 30% of our GDP if things continue. Now, obesity, lack of physical activity, and poor diet are actually going to surpass tobacco as the leading cause of cancer in the United States within the next 2 years. So the 10 to 20 years, pardon me. The obesity epidemic is a huge problem in terms of costs. It's going to increase costs and increase the number of people having diabetes, cardiovascular disease, orthopedic disease, and cancer. Obesity has been correlated with at least a dozen cancers. Now, looking at healthcare, in the United States, we very frequently waste resources because we don't distinguish what it is we scientifically know, what it is we scientifically don't know, and what it is that we believe. And indeed, we in American medicine have had a long history of confusing what we know with what we believe, and this has led us to doing a number of irrational things that waste tremendous resources. Some things like the Halstead Mastectomy, which we started doing in this country 120 years ago in 1894, the Halstead Mastectomy was actually a reasonable operation into the 1930s and 1940s, but we continued doing the operation despite the fact a number of surgeons actually questioned was it appropriate. We continued doing it in the 1940s, 50s, 60s, and into the 1980s even. It caused tremendous comorbidity, and it was much more of an operation that needed to be done for the small breast cancers that were being diagnosed in the 1940s and 50s. For the very large breast cancers that were being diagnosed in the early part of the 20th century, it was more appropriate. So here we have a procedure which was appropriate, yet over time became inappropriate, and we did it in an inappropriate era for more than 50 years. Bone marrow transplant as an adjuvant therapy in breast cancer was done in the United States from about 1980 to 1999, despite a clinical trial to show that it was beneficial, a number of studies to show that it made money for hospitals and doctors, but no studies to show it was beneficial to patients. Ultimately, when the studies were finally completed, it was shown that it was net harmful to women, and more than 200 breast cancer transplant centers closed in the United States within the 6-month period of time in 1999. So again, we have tremendous waste without appreciation of the science. Erythropoietin was widely used to stimulate red blood cell production in cancer patients, especially those getting chemotherapy in the 1990s, and then by 2007 there were a number of studies to show that erythropoietin, when used as it commonly was used, it was actually stimulating tumor production. So we were using essentially a fertilizer for cancer in cancer patients. And we also had tremendous problem in the United States over the last 20 years with mass prostate cancer screening. Again, a huge money maker, but very little scientific evidence to show benefit to the patient. So we have wasted resources, wasted precious resources. In many instances, when I talk about disparities, we have actually increased disparities by being non-scientific and focusing our efforts on things that seem to be appropriate but had not been tested. And this is why I think that in the U.S. we desperately need to focus on evidence-based care and prevention. Many politicians talk about how some of us want to ration medicine. It's not actually rationing of medicine we're calling for, it's rational use of medicine that we're calling for. Now let's look at some outcomes. And in terms of outcomes, we can look at cancer incidence, cancer mortality, cancer survival. We can even look at quality of life. I prefer to look at mortality. The other endpoints, there's always some discrepancy or debate. Quality of life, of course, is not very objective. Incidence can be changed by lead time and screening and that sort of thing, but mortality rates really are something that is more concrete. Now, disparities in health is the concept that some populations, however we define them, do worse than others. These populations can be defined or categorized by gender, race, ethnicity and culture, area of geographic origin, as well as socioeconomic status. In the United States, we frequently focus on race, and I'm going to show you some racial statistics. I would say be careful in interpreting racial statistics. They are not a biological categorization. They are a socio-political categorization, and indeed, our definitions of race change over time, such that an individual born in 1960 who is considered white in the 1970 census because his mother is white can easily be considered and was considered black in the 1980 census because the definitions changed to what race do you consider yourself to be. So there are many mixed race people. Area of geographic origin is actually a much better scientific term and respects the fact that many people come from many different areas of the world. Now, let's look at the U.S. population as a whole for a second. Cancer mortality rates, and these are age-adjusted cancer mortality rates to the 1970 census. They went from 64 per 100,000 in 1900 to 163 per 100,000 in 1970. Richard Nixon declared war on cancer in 1971. Cancer death rates peaked at 215 per 100,000 in 1991 and have gone down to 170 per 100,000 by 2010. That's a 20% decline in cancer mortality from our overall peak in 1991. However, the United States was the 31st country in the world to actually have a 20% decline in mortality, indicating that our healthcare system really was having difficulty getting all that's known about cancer control, prevention, as well as treatment to the population in the United States. Now, when we look at gender differences, the decline has been much greater for men in blue versus women in red. This from 1991 through 2010. When we look at the U.S. racial categorizations as defined in the year 2000, you can see the decline in blacks has been greater than the decline in whites. Native Americans and Alaskan Natives are seen in blue have essentially had very little decline over the 20-year period of time. Hispanic Americans have had a decline, and Asian Pacific Islanders have had a decline. And you will note that the black-white difference is frequently talked about, but there is a difference between whites and Hispanics and whites and Asian Pacific Islanders, which I actually think needs to be studied even more because we might be able to learn a little bit more about both the causes and the prevention of cancer. These are just death mortality rates from cancer for the U.S. Office of Management and Budget categorizations of race as well as by gender. Now, the determinants of health are social and physical environment, as well as health behaviors, as well as medical care, all of which can be affected by economics, by income, by race, by discrimination. Genes and biology actually are a very small part of the determinants of health. Another very interesting thing to note when we look at racial differences in the United States is that disparities seem not to occur in equal treatment settings. Indeed, equal treatment yields equal outcome, and race does not need to be a variable in outcome from cancer. However, the data clearly shows there is not equal treatment. Indeed, studies suggest that disparities in treatment may be due to cultural differences in acceptance of therapy, disparities in comorbid disease, making aggressive therapy less appropriate, larger proportion of, for example, obese black women in the United States, making it harder to do both surgery as well as chemotherapy for breast cancer. Access to care and convenience of access to care is a huge issue. Such things as just not being able to get a ride to the doctor has actually caused people to drop out of therapy, as well as we do have a problem with racism and socioeconomic discrimination. Now I'm going to look at lung cancer, breast cancer, and colon cancer and look at the declines that we have had over the last 20 or so years. You can see 20% decline in lung cancer, 34% in breast cancer, 39% in colon cancer, and let's dissect them out just a little bit. Now for lung cancer, dramatic declines in men from the late 1980s, not so dramatic declines. Indeed, the declines in women started only in the last 10 years or so. Much of the declines are related to this document. This is the Surgeon General's book on smoking and health, published in January of 1964. We have had a decline in smoking in men and women that's significant since the 1950s for men, 1965 for women. Indeed, that late decline in women compared to men is part of the reason why we have had a lower decline in death rate for women. 55% of American men smoked in 1955, and 35% of American women smoked in 1965. And we're now at about 21% of men and 16% of women. Here we have smoking prevalences by race and ethnicity. Note Native Americans have very high rates. Here we have smoking prevalences by gender, as well as smoking prevalence. How do you define the very heavy smokers? Note that people below the poverty level, over 21%, smoke in the United States. Looking at breast cancer now. Breast cancer declines have been wonderful, starting in the late 1980s. However, when we look at black women in blue and white women in red, you can see an increasing disparity. Indeed, there were no black-white disparities in breast cancer in the 1970s, and the disparity only started in the early 1980s, and the disparity is greater today than it has been any time in our history. We know that the declines in mortality are due to improvements in treatment, as well as awareness and early presentation. Screening mammography and clinical breast exam are actually the third reason why there's a decline in mortality. We know that receipt of minimum expected care is a problem. Blacks are less likely to get good care in the United States compared to whites, indeed a third less likely. Hispanics are about a quarter less likely to get good care for their breast cancer. Indeed, in Atlanta, where I am speaking to you from today, we have data to show that in 2000, 7.5% of black women who were diagnosed with a localized, curable breast cancer never got surgical removal of breast cancer. They were screened and diagnosed and had enough access to care to get that, but they did not get the tumor treated. I should say they did not get the tumor treated within greater than 1 year of diagnosis. Pardon me again. A substantial number of women of all races and incomes get less than optimal breast cancer care. Indeed, that's a theme when we talk about colon cancer, lung cancer, and other things as well. The provision of adequate care is usually a logistical issue and is not requiring new medical science. It's just getting known medical science to people. Now, looking at colon cancer, you can see the dramatic declines starting actually in the 1970s in men and in women. Wonderful declines in death rate from colorectal cancer. Looking at the declines by race, however, you can see black men in blue, white men in red, black women in green, white women in purple, increasing disparities in death rate that go back into the 1970s. Indeed, in parts of the 1970s and early 80s, there were no disparities in death rate, and the disparities have increased every year ever since. Here we also have data to show that the declines are due to improvements in treatment. Screening is actually very, very important to the decline in colorectal cancer, as well as awareness of symptoms and early presentation. In the United States, we have data to show that a substantial number of lives could actually be saved if we had very good, effective, complete screening programs. At this time, 40 to 45% of adults over the age of 50 and under the age of 75 are not being screened or are not up to date for any kind of screening. Now, I'm talking about screening. It could be stool blood testing, sigmoidoscopy, or colonoscopy. A substantial proportion of people with health insurance are not up to date in terms of their colorectal cancer screening. This slide is perhaps the busiest slide I'm going to show today. It's also perhaps the most disturbing. This is a Kaplan-Meier plot of the percent alive at 5 years, 60 months at the bottom of the page here. It is the percent, 0.5 is 50%, 0.8 is 80%, the percent alive at 5 years. And as you can see, red is stage 1, blue is stage 2, green is stage 3, yellow is stage 4. The dotted lines are uninsured Americans. The solid lines are insured Americans. I want to show you here that Americans who are uninsured have 5-year survivals inferior to Americans who are insured at virtually every stage. And I also want to note that in the United States, you are better off having stage 2 colorectal cancer with insurance than having stage 1 colorectal cancer without insurance. So insurance status does matter in terms of 5-year survival and in terms of overall mortality. So I'm going to sum up by saying that rational use of health care is necessary for the future economy of the United States. It's actually a security issue, with a growth anticipated over the next 20 years of going to 30% of our GDP. It's just not sustainable. We could actually decrease our healthcare costs and improve healthcare by using science and respecting science to guide our policies. Numerous examples of things that we do in American healthcare that cost a lot of money, that are really, really unnecessary or never proven necessary. I would also note, and many people in the audience, I'd be interested in what you have to think about this statement, that healthcare in many countries aims at keeping people healthy and preventing illness. And healthcare in the United States is so heavily focused on diagnosing people with illness and then treating them. I think we in the United States need to change our mindset much more toward fostering prevention. And most importantly, we need to respect and support the medical literature. We need to do high-quality, pertinent research. We need to educate professionals and the public as to what's been proven and not been proven. When we need to provide good care to all, utilizing the things that are proven to be effective and not utilizing the things that have not been proven to be effective. And in many instances, we use things that have been proven to be harmful. We need to intensify our tobacco control efforts in the United States. I would point out that there are several states in the United States where the prevalence of tobacco smokers in adults is 10%, yet the average in the United States is upwards of 16% for women, 21% for men. And we need to focus on good nutrition and physical activity. One of the great problems in the United States is people are eating too many calories. We actually have an abundance of cheap, calorie-dense food in an environment that does not foster physical activity and exercise. And this is a huge problem for us in the United States. And with that, I'm going to stop, and maybe we can have a long-distance discussion, or maybe some people have questions. Thank you very much.
So thank you very much for that, Dr. Brawley. Very interesting 25 minutes. So I have a couple of questions which you may wish to answer. The first of which concerns cancer screening and the differences between cancer screening in the US compared to Europe. So in Europe, the implementation of organized population-based cancer screening, especially for colorectal cancer and cervical cancer, seems to have been quite a large success in reducing costs, reducing mortality. And from some members of the Economics of Cancer Research Group found it also reduces disparities, especially across socioeconomic groups. So do you feel that within the next 20 or the next 30, 40 years in the US, the implementation of an invitation-based cancer screening program may occur, like in Europe?
I would love to see an invitation-based cancer screening um, program in the United States, very much like in Europe. That's something that we can learn from the Europeans and implement here very easily. Um, Ironically, much of the screening done in the United States is opportunistic. Much of it is driven by advertising, or in the case of colorectal cancer, in the case of cervical cancer, people who have a relationship with their doctor generally are encouraged to get colorectal cancer, but a large proportion of Americans do not have a relationship with a healthcare provider.
Yeah, I, I totally agree with you. The second question I have is, in terms of Obamacare or the Affordable Care Act, the expansion of Medicaid in particular, do you think that a greater emphasis on preventive care or allowing individuals to get preventative screening care through the Medicaid process may be one large benefit of the ACA?
I think that that could be a benefit of the Affordable Care Act. I am still a little concerned. You know, the Affordable Care Act is overwhelmingly insurance payment reform, and it's trying to use insurance payment reform to sort of lead everything. The problem with the Affordable Care Act is the insurance companies actually end up doing very well. The hospitals end up doing very well. Doctors take a little bit of a haircut in terms of income, but I think we could have done better. I support the Affordable Care Act. Don't get me wrong. I think it's better than our old system, but in many respects it did not go far enough in both encouraging quality and payment for quality of care, and it did not. There's going to be some politics in some of the screening. For example, we've already seen movement to make sure that the U.S. Preventive Services Task Force is overruled in terms of screening women in their 40s. It's very likely that CMS is our Medicare organization, they pay for elderly health care. It's very likely that they're going to be forced to pay for lung cancer screening, despite some advice that lung cancer screening is very expensive and saves very few lives when you actually look at the overwhelming expense. So the politics is heavily getting into this, and I'm actually somewhat concerned that the politics will actually harm healthcare overall and actually weaken the Affordable Care Act's abilities to make us more efficient.
Yeah, thank you for that. Another question I have here from Diarmaid Coughlin, who's also a member of the Economics of Cancer Research Group, is what do you think about increasing the awareness of causal agents in viral oncology?
Causal agents in viral oncology. We are having a huge problem with HPV vaccination in the United States. I wish HPV vaccination had been advertised more as a cancer preventative as opposed to as a preventative of a sexually transmitted disease.
Okay.
I'm being one who believes that HPV vaccination may prevent both head and neck cancer as well as cervical cancer. It's the lack of acceptance is because many people think of it as a license for kids to go have sex. Hepatitis B vaccine has not been rejected in the United States and has actually been fairly well accepted, and most young people in the United States have gotten hepatitis B vaccine. We do need to have a better conversation about viruses and cancer in the United States, and I think HPV vaccine could ultimately, in the next 30, 40 years, save us an awful lot of money.
So thank you very much for that, Dr. Brawley. I think those are all the questions that I have from people and from myself. So I'd like to on behalf of the Economics of Cancer Research Group, thank you very much for this excellent talk today. I think instead of me flying all the way over to Atlanta, the use of Google Hangouts or a webinar it's a nice way for presentations and dissemination of information to happen going forward, and we hope we have many more of these similar webinars as part of the Economics of Cancer Research Group. So thank you very much for your talk today.
Thank you. It's wonderful to do this. I really, really appreciate the invitation. It's a true honor, and good luck to you.
Thank you.